This particular case study has quite a few things in it, and we're going to walk through this description, and also I'm going to bring back some of those things that we want to know when we meet with our client. So the information that we're provided is a woman who's 63, has type 2 diabetes, which we know is a risk factor for cardiovascular disease. She's hypertensive, which is also a risk factor, and she uses tobacco. So when we look at our risk factor analysis, we have several things that come into play. We know that she has had a heart attack or a myocardial infarction. And what's typical with women, or I should say atypical, is that women will often have different symptoms. And so she had the event associated with exertion, and so she was shoveling snow. She said 2 out of 4 in severity, which is an angina scale. But when she sat down, it went away, but she had also some nausea, or she was sick to her stomach. So some of that is expected, but we also have some unexpected, because we normally expect it to be in the central part of our chest. It radiates up to the jaw in the left arm, but for her, she felt it in her scapular area in the middle of her back. So that's what's kind of different for women. She also identified that she was having this discomfort. She had to sit down, so she went to the hospital. 2 weeks ago, she was identified or diagnosed as having had a myocardial infarction, and so she had a stent placed in, and a stent is basically a solution to open up the coronary artery that is narrowed, and it is applied through going through the arterial system backwards and placed into the affected artery. Those stents often have medication in them to decrease the likelihood of having accumulation of clots or atherosclerosis. So it helps to build the support of that vessel, open up that vessel, and allow blood flow to occur, and also to decrease the risk of more atherosclerosis. So she now says, this is what's happening now, is that she has shortness of breath on exertion, and particularly when she carries things up a flight of stairs with her full basket of laundry. We don't know where she lives, but it could be that she has her laundry in the basement, but everything else is okay. Now, what we know is, if we look at that mnemonic, we look at the onset. We know that. We know her onset is she gets this discomfort when she walks up the stairs. We know what provokes that shortness of breath, when she does something with exertion. She has not described the quality of it. Shortness of breath really doesn't radiate. We don't know the severity of her shortness of breath, but we know when the symptoms have come, and we don't know if she has had the shortness of breath for a long period of time. And we do know that if she sits down, that she has, it's relieved. So what we don't know is a lot, but what we do know is some. Just for a little information, I wanted to refer you back to getting an idea about what we can see her capacity is right now, and that's that table that I put in the previous presentation. General housework, hanging laundry, which actually is pretty taxing because you put your arms over your head, which increases blood pressure. Yes, she can do that. She can push a grocery cart. We don't know if she can push a lawnmower. But we know that she can't carry laundry up 2 flights of stairs. So we know she has a 3 to 4 Met capacity as she's described it so far, which is quite low. We're given a lot of information in bullet format in terms of her medication, when she takes it, what her dosage is. We have her allergies. We also see that she has risk factors for medical history, family history, also her age. We know that her father died at 62 and she is 63, so that's a concern. We know that she smokes 1 pack a day, but we don't know how long she has smoked, which has to do with the exposure of smoke. Sometimes we'll see pack years, and we can look at that at another day. It's a number of cigarettes, that number of packs per day times the number of years you've smoked that number of packs. So if somebody has a high pack year, that means that they're either smoking for a long time, a lot of cigarettes, or a combination of both. She only drinks 1, maybe glass of wine per week. She has a sedentary job. Her children are grown. She is educated. And she has a vehicle. So we have table 2.2 to look at risk factors and criteria to determine that level of risk. And then there's some information about common medications in Appendix A, and that's in your guide, both in your guidelines book. We know that she does have a little bit of information about her diet, and she's a breakfast skipper, and she does eat fast food quite a few times a day. We know that she does get some fruit and vegetables, but she doesn't sleep enough, and here again is that heavy snoring. And so we're going to wonder about some other issues that are going on outside of exercise that are really not our lane, but we can make recommendations, give general guidelines, and also encourage more investigation. She was diagnosed. We know her diagnosis at this point is that she had the left anterior descending artery, which is the important one. It's a big one, and it really is the major one that feeds your left ventricle. So we know that she has a decrease of a mild reduction in her function, which means her cardiac output has probably decreased. We know she has diabetes, hypertension, obesity, sedentary lifestyle, and she uses tobacco. So for the questions, the first question has to do with what is the primary disease and what comorbidities. Well, that was completely listed, so what I would list for that question is that she has coronary artery disease, has had a stent, and she has diabetes and hypertension. So what do I put for the underlying pathophysiology? Well, you want to look at what kind of factors have contributed to where she is right now. And she probably has the standard atherosclerosis and some contributing factors that have played a role in her atherosclerosis development. She may have the hypertension that she has could mean that she has kind of an overactive sympathetic nervous system, and she has most likely a lot of sodium in her diet because of her frequent fast food, and she's also hypertensive. So we're looking at what kind of components are involved in her disease. So that is question B. Question C, what are the signs and symptoms? Well, all we really know about is that she has that atypical angina, and that her symptom now of shortness of breath is relieved with rest. And so we know that she does have some cardiovascular limitations, and I just wanted to document that she does have some differences in how men and women may experience angina. Is medical clearance recommended? Well, if you look at figure 2.2 on page 35, and I like when you identify that you've done that because she has known cardiovascular disease and she has the medical clearance is recommended, and she does need to have a physician make that recommendations. Are there any contraindications? And with that, I'm going to refer to you to always look at page 116. So 116 in your guidelines manual, or it is basically chapter 4, table box 4.1, It gives you your absolute contraindications and relative contraindications. So she really doesn't have any. She doesn't have the known obstructive, although relative you could say, but she has known obstructive left main coronary artery stenosis. But she has had that stent, so I would put that as no contraindications. If she wouldn't have had treatment, then that's a different story. So for her medications, the first is to look at Appendix A, page 470. And the newer book does not have quite as much information in Appendix A as the previous guidelines book because it's becoming more and more difficult to summarize all of the medications in a table format. So what you'll see on table A1 is the medications that are most likely going to have an impact on exercise and how they influence the exercise. So if you take a look at page 471, you'll see that cardiovascular medications are separated into types, into beta blockers, vasodilating agents is in the next page, antiarrhythmics with different classes. And then you'll see respiratory medications, hormonal medications, central nervous medications, and most of the time, this is a good way, once you know a classification, you can look at your manual and see if it fits. As you look at the Appendix A on page 470, then we know that we've got a little bit more to discuss. So the first one is when I ask you identify what is the action and does it have any impact on the exercise response. So atorvastatin is a cholesterol reducing medication, and it's a coenzyme A reductase inhibitor, and you can just Google that medication or look online at drugs and you'll find out what it is. And just a brief message of what it is, you'll see that's a very typical dosage. The aspirin is to reduce platelet aggregation, and this is a very common, this is a baby aspirin. The clopidogrel is to destabilize clots. So the aspirin and both clopidogrel, both of those are for clots and to decrease the risk of her having blood clots. The metformin is the most common type 2 diabetes medication that is given. It is the first medication, and when we get to diabetes, we'll talk about it a little bit more. But what that does is it works at the liver. It decreases the production of new glucose and increases glucose uptake, so it monitors or keeps your blood glucose level low or helps to regulate it. Lisinopril is an ACE1 inhibitor, and if we look at what that says on page 471, an ACE1 inhibitor has it can decrease, its focus is to decrease systolic blood pressure at rest and exercise. And if you look way over to the right, exercise capacity, it can increase tolerance if an individual has heart failure. So that's one thing that we can kind of keep in mind. But the main thing is during exercise, we know that the blood pressure response is going to be impacted. And anytime you see an allol, you know that that's going to be something you want to look at. Or, excuse me, lisinopril, the april. The allol is a beta blocker, and that is one that you are always going to pay attention to that is going to have an impact on exercise response. It reduces or no change in exercise cardiac output. It reduces blood pressure via heart rate response and also blood pressure. So cardiac output is heart rate times blood pressure. So the cardiac output can be decreased during exercise or at rest. And we know that there's an inotropic and chronotropic effect of that beta blocker. And we need to know that when we do an exercise test. Nitroglycerin is a non-specific vasodilator that's used with angina. So when a person is experiencing angina, they pop a couple of those, pop a nitroglycerin underneath their tongue, and that's going to cause a non-specific vasodilation, and sometimes people will say they get headaches from it, and that is important to know too. So only metoprolol will have an impact on the exercise response. So for that question, we want to identify what the drug does, and these are all, I should have put in there a normal dosage, recommended dosage, and the only one we have to be concerned about is that metoprolol. But we still want to make sure that we are aware of all the medications and what effect it will have on the exercise or cardiovascular response, and also exercise tolerance. We're given the objective and laboratory data, and this is where you might have to go and say, what is this? What is this? But what we do see is that she's still smoking and she looks fatigued. We see that her blood pressure, her systolic is a little elevated. Now that could be because she's nervous. We would see a heart rate of 48, but we know that's normal because of her medications. Normal respiration. We have a 38-inch waist, and we know that her oxygen saturation at rest is great. Now the one word, a couple words that you might go like, what is that? Is the cardiovascular, no carotid brutes. Now it could be pronounced brute or bruit. It depends on who is saying it. But that is an abnormal sound that's heard through a stethoscope, which can be a really, if it's a carotid, if it's taken at the carotid artery, it's a big marker of atherosclerosis with a risk of stroke, heart attack, and death. So that's good. And other than that, it says that she has a little bit of murmur, ejection murmur, but she doesn't have any edema, and that's going to be an indication for heart failure, and everything looks normal for her cardiovascular except for a little bit of that murmur. She has a little bit expiratory wheeze, nothing noticeable about that. She doesn't have, now she does have decreased sensation in her feet, and what that it would be from is potentially the type 2 diabetes. You may lose peripheral sensation, and that's one of the key things associated with diabetes that we'll look at later. Watching her walk, she walks normally, she doesn't have any joint discomfort, and she has good range of motion. We know the only chemistry that was done was her blood glucose. It's a little elevated. We don't know to what, but it says it's elevated, and the remainder of the labs are normal. So with that, are there any concerns or limitations to consider revealed in the objective information? And there doesn't appear to be any concerns or limitations. What we do know is that she does have some risk factors. We do know that the snoring could be associated with sleep apnea, which is a potential contributor to her diabetes and hypertension, and but that doesn't limit her to any exercise. The other clinical diagnostic test is that she has a normal response with her EKG, and as I had mentioned, because it is where she had her coronary artery atherosclerosis, it says that she has some anterior wall hypokinesis, and the left ventricles is the major part of the left, is the big part of the anterior wall. Low movement, that would be expected because it's a damaged muscle. Her ejection fraction is 40%, which is low, and that is something that hopefully we can have an improvement with her exercise program. Now, what we were given is her clinical graded exercise test. She has had a modified Bruce, and you'll see the workload is listed in the first category, the first column. And unless you've had Dr. Michael's class, you've only been introduced to the Bruce, it starts several, I think the normal Bruce starts at 1.7 miles per hour at 10% as a warm-up. So because she's post-MI, it's very common to have a modified Bruce to see for her past stint, I should say, to get a test for exercise programming. So we know that she did 9 minutes, which is great, but she only has a peak workload of about 5 minutes. So when we have this cardiovascular graded exercise test, we want to look to see what are the normal cardiovascular responses. And some of this we should have a real clear idea based upon your knowledge of from your exercise physiology class. We know that each stage is 3 minutes, so she went 9 minutes. And we have her resting information, and see now her blood pressure is 116/74, so that's really great that she's in a normal blood pressure response. She has no rhythms that are concerning and no EKG changes. So we see that if we look at her heart rate, we notice that we should see about a 10 beat heart rate response, 10 beats per minute. But what we do see is that her heart rate increases as expected. We see her systolic blood pressure increase as expected. Her diastolic will either stay the same and sometimes go down a little bit, but that is absolutely what we should see with an exercise test. We see that her ratings of perceived exertion increase. This was not a maximal test. She got to a 14. This was, she just basically was tired, but remember she came in looking kind of tired. She has no arrhythmias, which are great, and no EKG changes. So we have a really great exercise test. Now the one thing that's not measured that I want to mention is that her RP, her ratings of rate pressure product should be evaluated as well. The rate pressure product is heart rate times the systolic blood pressure, and that's an indication of myocardial oxygen uptake. And so if we measure the 70 times the 116, move to 88 to 122, and then so forth all the way up, we find that she has a normal increase in her rate pressure product, and the normal range is for maximum exercise is between 25,000 to 40,000 milligrams of mercury per beat per minute. And hers, if we do her top 131 times 154, we get 20,174. So her rate pressure product or her myocardial oxygen uptake is great. So based on her exercise test, there is really no concern that she shouldn't participate. So that is the second part. That is B. Should we consider considerations and expectations? Well, she is definitely a candidate for comprehensive secondary prevention. A secondary prevention is when someone has known or very early disease, and the plan is to decrease the impact of that disease. Tertiary is to, or primary is to prevent. Secondary is to decrease the impact of the disease. The consideration of, and we would expect some improvements. Do we have any signs and symptoms? Well, her shortness of breath is the biggest symptom. The meds are actually going to help her with her symptoms, and an exercise plan should help her with improving. So on page 232 to 237 is the cardiac rehab stuff, and I don't expect that you have done that, so I am not going to expect you to have done a tremendous amount. But what I do want to mention is that I'm going to provide general recommendations, and I think that in many cases I'm probably going to change the way the question is asked and ask for less, not quite a 12-week, but maybe just a general starting exercise recommendation. So I'm going to correct that in the case studies. But for cardiac rehab, this person is really going to be recommended, is a good candidate for that, and we would improve her MET capacity and also her impact many of her risk factors. And the exercise equipment that would be available at most outpatient programs would be a treadmill, stair stepper that is when you sit and move your arms and your legs, or a cycle where you're pedaling a little differently and where you're doing in a circle and you have the arms like a Schwinn Airdyne. The recommendations are on page 235, and because of her beta blocker, I am gonna I think the recommendation of using the RPE is probably going to be the best, and our goal would be for her to start 3 days per week, and that's usually covered with healthcare, with insurance, healthcare insurance. And we really want to move toward 5 days a week. We're going to progress to a strength training program once she has a good toleration of her exercise, her aerobic exercise. Because she has been sedentary, we'll probably start with short bursts or short bouts of exercise and do maybe kind of play it by ear, but maybe 5 minutes a break, 5 minutes a break, 5 minutes a break. And funny how I didn't put that in the writing, and I apologize about that. This would be the general exercise response or recommendations for strength training and for the exercises. And as you look at the recommendations, we're looking at just major muscle groups and start with 10 to 15 repetitions. Have an RPE of 11 to 13, and then progress to 1 to 3 sets. Issues that affect would be that she has been sedentary, she's fatigued. Start small, and also encourage her to look at her sleep schedule. Maybe she's not getting enough sleep, and perhaps look at her encourage her to talk to her physician about her snoring. And then we would make sure that we would follow her goals, her preferences with the exercise response or recommendations. Further education would probably be associated with her cardiac rehab. Many times there is an educational component that goes with that, and nutritional guidance, smoking cessation is going to be really important, and recognizing she has a family history is going to be part of her education as well. What we want is for her to take her medications and maintain physical activity.